Very good afternoon, ladies and gentlemen. We'll begin the post-lunch session now in a couple of minutes. May I request the delegates who are standing outside, if you finish your lunch, to kindly come in and take your seats, please. Requesting the presence of the chairpersons for the next session, Dr. Dilip Kumar, Dr. Suresh, Dr. Shyam Krishnan. Post-lunch session of day 1 of Kasicon 2023. Phones on silent or on vibratory mode once again. Gentle reminder. Ladies and gentlemen, may I request you to kindly come in and take your seats, please. We start with the post-lunch session immediately. May I request the chairpersons to please kindly come in. We have to maintain time. We have a very jam-packed post-lunch session of day 1 of Kasicon. Once again, may I announce the names of the chairpersons. Our esteemed chairpersons for this post-lunch first session are Dr. Dilip Kumar, Dr. Suresh, Dr. Shyam Krishnan, please. And the first speaker is Dr. Ajaykumar Parasala, and the other speakers are Dr. Jayachandran from Kottayam, Dr. P. Rajan from Calicut, and Dr. Tom Thomas. If you're here, sirs, kindly take your seats on the dais. Once again, I'll invite the chair, Dr. Dilip Kumar, Dr. Suresh R. and Dr. Shyam Krishnan, speakers for the session, Dr. Ajaykumar, Dr. Jayachandran, Dr. Rajan, and Dr. Tom Thomas. Request you to kindly take your seats on the dais, please. Time is 2 p.m. and we start prompt on time. Dr. Ajaykumar, sir, will be presenting first. Over to our esteemed chairpersons. Over to you, sir.
May I request all the delegates to come inside? We are going to start a new session, an interesting session on diabetic food. Professor Ajaykumar is going to talk on offloading of diabetic food. Let us start. Over to Dr. Ajaykumar, sir.
Respected chairpersons, senior faculty members, my dear teachers and friends. At the outset, let me express my sincere gratitude for this wonderful opportunity and congratulate the team led by Dr. Bipin and Ranjit for the excellent state conference going on. So I'll be talking on an important topic in diabetic food, which most of the treating doctors forget. That is offloading in diabetic food management. Dear friends, I bring greetings from Trivandrum. You know the poster of Lord Padmanabha, completely offloaded. So the richest God in the world is setting an example of offloading. And the best offloading method is bed rest. That is the advantage you get when the patient is admitted. When he is discharged and goes home, the offloading part, the surgeon as well as the patient forgets. Recurrence is the result. Dear friends, as you all know, neuropathy and vascular disease are the main culprits. This poor man is trying to put his Hawaii chappal. See how difficult for him to place his feet inside. He is putting it against the wall to keep his foot inside the very simple footwear. So this is the main problem our patients are suffering. And this is the result. We get a lot of necrotizing fasciitis, multiple infections, ending either in amputation or losing life. Dear friends, even the nature tells if there is an injury, please offload. So when you think about diabetic foot offloading, you have to keep in mind that it's not a static problem. It's a biomechanical problem. Patient has to walk. With all these deformities and disabilities. Dear friends, the strategies for offloading are pressure reduction to enhance healing and prevention of ulcer recurrence. So, of the 6 major components, offloading has got a very important role. If offloading of the foot is not done, what will happen? A grade 0 ulcer or a callosity becomes an ulcer, then it becomes a complicated ulcer, and it may lose your foot or toes, and even if you treat it, recurrence is the result. Dear friends, a lot of guidelines are there, of which International Working Group has come with the guidelines for offloading, and this is the offloading diagram. Because of the paucity of time, I am not going to explain. Most of the offloading takes care of foot from the insole to the knee. Why? Because the pressure has to be reduced. In most of the cases, you need orthosis. So, practically speaking, what are the offloading options we have? Crutch or walking frame, total contact cast, ball or iron cast, footwear modifications, half shoes, clogs, insole reliefs. And before going to the topic proper, I request you to note that a lot of offloading equipments, measures, orthoses are available, but the affordability and accessibility is a major problem as far as our patients are concerned. Less costly but effective devices have to be made available. This is the list of offloading orthoses and footwears we use. Regarding total contact casting, it is a very effective and gold standard offloading device, very economical and suitable to our patients, because it produces a forced type of compliance. Patient cannot remove it and he will bear it. And what happens in total contact casting is a pressure point and is made as a horizontal surface, as you see in the diagram. So the pressure exerted by the external force in one point is dissipated to a wider surface, as well as the pressure transmits through the sides of the cast and down to the undersurface. These are the two mechanisms by which around 60 to 70% of the weight is offloaded. Dear friends, there are various types. I am not going to details. Instant casts are available, splittable casts are available, modern casts are available, but ordinary plaster of Paris cast is very easy to put. Only thing is it needs a few days training and some precautionary measures. A lot of evidence is there in the literature, and the fifth one you have to keep in mind. It is suitable for our country, but you have to use it very carefully. Why? It's a totally neuropathic foot. If there is an injury or some infection occurs, patient will not know, the patient will present late. So you have to be very careful. Dear friends, we have many temporary offloading devices. One is an air cushion device, and second is our own contribution, a device which can be fitted into the shoes or the chappal of the patient. Third is a modified felted form, which I will show one by one. This is made from a pair of surgical gloves like this. It is self-explanatory, and it is kept with an elastoplast, adhesive elastocrep bandage made in the shape of a pillow. So it contains some amount of trapped air as well as rubber. It acts as an air cushion. This is actually a symbolic representation. You finish the dressing. After that, you put this one proximal to the ulcer. So patient will be walking on the heel or hind foot. Even if there is a stamping, this will protect the ulcer. This is very simple method. You can keep a similar form fixed to the appropriate footwear. The patient cannot afford a temporary footwear. This is ordinary foam sponge. If it is a bigger ulcer like this offloading small devices cannot be used, where instead of felted foam, which is a medical grade foam which is costly, this can be used. This also after putting the dressing. And footwear modifications, as you all know, wedge footwears, forefoot, midfoot, hindfoot. Midfoot, you know, rocker bottom is the end result of most of the charcots, where your weight is borne only in the forefoot and hindfoot. And this rose color one is the felted plaster sort. It's a material which molds, and there is total contact cast. So it needs a lot of preparation, measurement and other things. And special insoles you can use. These are the small commercially available insoles. You can remove these blocks and keep the ulcer area free. Or you can put special total contact insoles into your shoes. Only thing is you have to buy a shoes one number more bigger in size. So my dear friends, if in a neuropathic plantar ulcer, if you do not offload, the patient will walk to death. Dear friends, if you don't offload the diabetic foot, that is the fatality is the result. Total contact casting, irremovable devices are the gold standards. Choose the modality of offloading based on individual merits and demerits, and taking into account the economic, socio-economic status and educational status of the patient. Thank you very much. What George Bernard Shaw said, a society will easily pay a big amount to a surgeon for amputation, but nothing to save a limb. Dear friends, this was an attempt to sensitize you about an important aspect of diabetic foot, and I invite you all to Trivandrum for the first annual conference of Diabetic Foot Society of India, to be held on 15th and 16th of July. And you are all welcome. We are all general surgeons doing a lot of work, and diabetic foot is a major share in our work. Let us do justice to our patients. Thank you.
Thank you, Professor Ajaykumar. Any questions or any doubts about offloading?
Sir, excuse me. Do you do surgical offloading?
Yeah. So I have not touched the surgical offloading. It's a big subject. Surgical offloading has got a major role. For example, if you have a forefoot ulcer, if the TA shortening is the problem, you can lengthen the TA, you can do gastrocnemius suspension, you can do sliding osteotomies. It's a big area. I will not be able to finish it.
When do you suggest to go for surgical offloading?
Yeah, if there is a definite localized surgical deformity which causes pressure point and ulceration, the indication is surgical offloading. Okay. This is a temporary offloading to attempt to heal the ulcer. If it recurs, you have to do surgical offloading.
Thank you, sir. Thank you, sir.
Thank you, Ajay sir.
Thank you, sir. We'll have to move on.